Well, welcome everyone. We'll be getting started shortly. Thank you so much for taking time to join us today for this webinar on Medicaid and social determinants of health. We'll be discussing options for health centers. As folks continue to pile in, please take a moment, introduce yourself in the chat, your name, your organization, where you're joining us from. Make sure that you are on mute, and we'll be getting started in just a second. Thanks so much. Great. And as folks are introducing themselves in the chat, Kathy, if we could just move forward, we're going to go ahead and get started. Great. And so once again, good afternoon and welcome to our webinar's topic today for Medicaid and social determinants of health, options for health centers. Our webinar is brought to you by both HRSA and Corporation for Supportive Housing. CSH is a national nonprofit housing advocacy organization in CDFI. We work with organizations, cities, states, and communities across the country to promote supportive and affordable housing, mainly for vulnerable populations. We have a number of different lines of business, including consulting, technical assistance and training, lending and loaning. Kathy, if you could please advance the slide. Thank you very much.
Sorry, it's slow on my end.
Great. And moving forward, one more. Thank you. Great. So my name is Jamie Blackburn. I'm a senior program manager for our federal technical assistance team, and I'll allow my colleague Marcella to introduce herself as well.
Hi, great to see everybody today. Marcella McGuire. I am the Director of Health System Integration from CSH. I'm coming to you from Philadelphia, Pennsylvania, and excited for today's conversation and dialogue. So many opportunities out there, and we want to see health centers be able to take advantages of them. Thanks, Jamie.
Thanks so much. Next slide, please. Great. So as we mentioned, for today's webinar, we're going to be covering a number of very interesting topics. We're going to be jumping into getting an overview and an understanding of the Center for Medicaid Services guidance letter and some of the state policy levers that you have at your disposal to address social determinants of health. We're going to talk about some of the examples, best practice state examples from around the country that we're going to dive into a little bit that you might be able to learn from, learn a bit about the role of health plans in addressing social determinants of health, and then how get an understanding on how this can impact health centers in the long term. If you have any questions at any time, please feel free to drop them in the chat. We will be monitoring that closely. We're happy to stop, answer questions as we go. So please don't hesitate. We're happy to answer any questions that you may have. Next slide, please, Kathy. Great. So I'm going to hand this over to Marcella now as we dive in and get that overview around the official guidance letter that was issued by CMS.
Thanks, everyone. So today we're really starting to talk about a particular state health official letter that came out in January 7th of this year. Now you may say, wait a minute, that was the Trump administration. We're in the Biden administration. Haven't things changed? And yes, in many, many ways, things have changed. But I really, as we see that letter, as just a really comprehensive effort of the many different levers that states have when they want to begin to address social determinants, or what we're increasingly calling social drivers of health. I don't know who came up with that one. We don't have to change the acronym, which is really helpful, but I really like the switch from determinants to drivers. Determinants makes it sound like it's determined, it's decided, I can be this healthy, I can't be any healthier. Drivers merely means to talk about these are things that influence, but these are things that can be changed. So I really like the drivers term more, but the two terms are being used interchangeably right now. I expect to see with a stronger equity focus, we'll be moving into talking about drivers, but I really like the drivers term because it gives us a lot more hope than the determinants term. So the state health official letter, next slide, please, is is really a comprehensive look from a CMS perspective about how we shift. The current reality we have is that we're working with people who experience complex care needs, people who have multiple needs. I'm experiencing homelessness and I have a behavioral health issue. That's where my career has been. Or I have a complex care need and a housing instability need. I have a complex care need and I'm incarcerated. I have, diabetes and schizophrenia, and I have to figure out how to manage both. The management of those systems means you have to operate within multiple different sectors. There's a clinic for this and there's a clinic for that. Health centers really try to be comprehensive care, but we're increasingly being pushed. Health centers are also increasingly being pushed into address social determinants. So maybe you've been able to integrate physical health and behavioral health care, and that's a huge amount of work and really important. But now we're being asked to integrate social care. We're being introduced not just to work with people on nutrition, but make sure they have access to food, make sure they have access to housing, make sure they have access to transportation to engage with us. So right now, the current reality is that most of that negotiation in multiple systems comes from individuals and families. They've got to work to get to the behavioral health clinic and the housing authority. They've got to work to get to the area agency on aging and the homeless shelter. And and the more systems that you need assistance with, the less likely you are to be able to negotiate between these systems. Providers, sometimes like health centers, do some of this negotiation. There's really at the public sector level, commonly not a lot of collaboration. The future vision is that we want the least amount of burden to be on the individuals and families and communities. Providers like health centers can stay in the middle, but we're really trying to build, and that's what the letter is really trying to build and say, here's the greater possibilities in public and private sector collaboration. Here are the different levers states can use in order to try to build that. And we're going to talk today about North Carolina and California in particular, and some of their efforts around what's commonly being called whole person care. I interpret whole person care as saying, we're not just concerned with behavioral health care, we're not just concerned with physical health care, we're concerned with the whole person. So if the person can't access transportation, can't access healthy food, doesn't have access to a refrigerator in order to store their insulin, we have to think about those things as well. So we're trying to make this shift. Next slide, please. So where did the conversation begin? The conversation began with Dr. Jack Geiger, who is one of the founders of the Community Mental Health Center movement. And I just love this really, really simple quote. He was seeing people who were experiencing malnutrition in rural, I believe it was Alabama. And the last time he checked the textbook, specific therapy for malnutrition was in fact food. As a physician, he was not able to prescribe food. He was not able to access food. He could prescribe all kinds of fancy medications, but he couldn't prescribe food. But the problem was the answer to malnutrition is food. Next slide, please. So we commonly call this what I believe the next slide is what we call it is the wrong pocket problem. So you as a provider know what needs to be done, and it's a tool that isn't in your toolkit. So I'm a physician, I'm seeing somebody I'm not, but if I was, and I was seeing, or a nurse practitioner or whomever, or a nurse's assistant or a social worker, and I see one who's hungry, I need to be able to get them food. We didn't need to go to our advanced educations to do that. But SDOH is the health world's way to look at what we call the wrong pocket problem. I know what the solution is. The solution to homelessness is housing. The solution to malnutrition is food. But as a healthcare practitioner, I can't prescribe what we know is right. So in order to be able to access those other resources, we need new partners, we need new resources, we need to understand new systems, and we need to build a holistic, whole person care system so that you can easily both refer to these entities and then also make what we call a warm handoff. For a lot of people, particularly with complex care needs, people with long histories of alienation from the healthcare system, people's experiences of institutional and systemic racism, they're not getting what they need when they try to connect with these systems. We really want to move beyond the referral system. Hey, here's a piece of paper, take this piece of paper, go over there. And we want to begin to move to also what we call warm handoffs, meaning that we accompany people, we make sure they can connect to these other systems, we make sure these systems can respond to their needs, and we continue to stay engaged with the individual. So the wrong pocket problem is, I know what I'm as a healthcare professional, I know what folks need and I can't prescribe it. So how do we make sure people get what the resources they need? Next slide, please. I have a long history of talking too fast. So if I'm talking too fast, please let me know. Jamie's laughing, she knows. So it's really important that we understand all of the different pieces of the healthcare system, of what we call the healthcare ecosystem. A lot of times I'm in scenarios and meetings where we see people who are we're going to someone who's helpful, but they're not the right kind of helpful. The metaphor I have for this one is if I go to my high school English teacher and I'm asking them for help with my equations, they're a helpful person. They're a teacher, but they don't really know much about equations, about my algebra equations. We need to go to the right teacher. So it's helpful to know what those teachers are in our healthcare system. So there's our primary funders. They set our policy, they decide funding, et cetera, at the Health Resources and Service Administration. That's the key funder for health centers. And then many of you are also billing Medicaid and Medicare, which is the Center for CMS at the federal level. At the next level down, you move to your state Medicaid offices. These are looking for much more opportunities for engagement. You know, the old metaphor holds that if you've seen one state Medicaid plan, or mantra, not metaphor, if you've seen one state Medicaid plan, you've seen one state Medicaid plan. But states are really being innovative in collaboration with CMS in the social drivers of health space. For all but 9 states of you, you have systems that are driven by managed care and driven by health plans. Health plans are being asked to do more and more and more every day around social drivers of health, around homelessness, around housing, around long-term care, et cetera. Just to give an example, I will highlight California asked in their home and community-based services plan for over $1 billion to give to health plans, to get health plans in communities working around homelessness and organizing that. And that looks to be approved. So it's going to be really important. Health centers may not have the stronger relationship. Some do, some don't with managed care because most of your funding comes from another way, but you need to understand that healthcare ecosystem in your community. And if you're a state with managed care, you need to understand who's covering the people in the communities that you're serving. And then finally, health systems and hospitals, they're the direct care providers, and they are, of course, your partners as well. Next slide, please. So this is the state letter. There's a link here. On January 7th, CMS released this letter aligning a variety of state policy levers at disposal for states to address social determinants or social drivers of health, how states should be thinking about addressing housing, addressing nutrition and food access, addressing transportation, addressing interpersonal violence. There's nothing new in here, but what I love about this letter is Medicaid is so complicated, and it's like this was a completely comprehensive sort of every tool in the toolbox is listed in this letter, particularly in what states can ask from their health systems and hospital systems, what they can ask for their health centers, and what they can ask for their managed care organizations. So I really recommend people take a look at this. This is a big of interest to CSH because if you are an entity that's delivering health-related housing supports or housing-related supports, this supersedes the 2016 guidance where CMS had, 2015 guidance where CMS had originally said, yes, the services in supportive housing are Medicaid services, and in particular, their home and community-based services. So the link to the letter is there, and that's a lot of what we're going to be talking about today. Next slide, please. So in particular, we want to talk about, and this is near and dear to the heart of any of those of us who work at CSH, is housing and housing related supports. The first thing is to be utterly clear, Medicaid will not cover room and board. That has not been shifted at this time. We are not seeing indications from this administration that room and board expenses, or what those of us in the housing world would call capital, what it takes to build the building, operating, what it takes to keep the building operating without charging people very low rents, because that's what they can afford. All of those coverages are not covered by room and board. But the third legged stool for supportive housing is services, and housing related services and supports can be covered. This may include home accessibility modifications to allow someone to remain in their home. States are allowed to, and some choose to, and some choose not to, cover one-time community transition costs, such as security deposits, utility acquisition fees, paying back utility rents, essential household furnishings. If any of you have ever collaborated with folks in your state's Money Follows the Person program, that state's efforts to move people out of nursing homes and institutions and help them live live in live safely and successfully in the community. So community transition costs are those funds that help people make that jump when people are extremely low income. And then finally, and this is a long-term place, we're seeing a number of states, I've got a map coming soon about housing and tenancy supports. Pre-tenancy services, what it takes to get someone into housing. So help them pull their documentation together, determine what their, apply for rental subsidies or rental assistance in different long-term ways. Help people get their documentation together, help people, train them on how to work with a landlord, engaging with landlords, et cetera. Those are the pre-tenancy services, the services that help people obtain housing. And then tenancy sustaining services. These are intensive in-home services that help people, particularly people with disabilities or people who are aging, stay and remain good tenants. So next slide, please. This is not up. I believe the next slide is the map. So your question is, hey, I'm in California, I'm in Nebraska, I'm in Iowa, I'm in Kansas, where am I? I'm in New York, I'm in Pennsylvania, actually. Does my state cover it? So the answer is, if you're in a purple state, the answer is yes, your state covers tenancy support services. They may define those services differently. They particularly may define it for different populations. So in Pennsylvania, it's for folks with intellectual disabilities almost exclusively. In New York, it's for people with mental health and behavioral health disabilities. In California and in Rhode Island, it's both very broadly, and Minnesota, it's very broadly focused on people experiencing homelessness. In Washington State, it's people experiencing homelessness and at risk of homelessness. In Oregon, it's people with substance use disorders. So the states in purple have somewhere where they are covering tenancy support services, often differed by population. No state we are seeing is completely comprehensive. Washington State, I would say, is probably the broadest benefit that we see. It's called foundational community supports there. In Minnesota, it's called housing stabilization services. In North Dakota, it's focused on behavioral health and people with, and it's called housing support services. California, as I say, is also county by county. Your county may be part of the whole person care pilot and may have chose to offer these services, or they may not be. And whatever the place, they're working on switching to CalAIM. So know that these services are out there. The states that are in in green are negotiating. They've requested to be able to cover these services. They're negotiating with the federal government to do an amendment there. There's a permanent supported housing pilot in Vermont. Arizona is very comprehensive. They're even looking to cover outreach and engagement services. Montana is behavioral health focused as well. So is Illinois. New Hampshire is very homelessness focused. So they've got something submitted to the feds and they're waiting to hear back from that. And then you've got states that are planning things as well. North Carolina has it in a couple of counties as parts of their pilots. So really important to know what your state's doing around this issue and advocating for both that they cover housing support and tenancy support services, not room and board. Very important to tell people you are not looking for room and board, because that shuts the conversation down right away. But you're looking for tenancy support services to be covered. So yes, and with that, I believe I turn it over to Jamie. Next slide.
Great, thanks, Marcella. So of course, when we think about social determinants of health, we automatically, of course, at CSH, we go to housing and we think of housing as being that platform. But there are certainly other services and supports that are outlined in this guidance that CMS talks about that we're just going to cover briefly for the next few slides. So of course, housing being very, very important, but of course there are other needs as well. And one of those things includes non-medical transportation for folks that are receiving Medicaid funded home and community-based services. So that can be anything from grocery shopping, taking you to something related to employment or seeking employment, other essential non-medical needs, and transportation around that, which of course is very important. Next slide, please, Kathy. We also think there's also home delivered meal services. And so when the most commonly thought of example for this would be sort of Meals on Wheels type service. However, there are many other different types of organizations that can provide this type of service beyond Meals on Wheels. But the key is to bring home delivered meals to folks that are highly vulnerable or maybe have mobility or accessibility issues. Next slide, please, Kathy. Great. So educational services. So outlined also within this letter, CMS explains how states have the option to cover Medicaid services for eligible beneficiaries in a school setting if they're determined to need those services and they're provided by qualified Medicaid providers. Next slide, please, Kathy. CMS also supports states' efforts to incentivize work and community engagement, particularly for non-elderly, non-pregnant adults who are eligible for Medicaid on a basis other than disability. So for those individuals, Medicaid will also cover certain services supports related to employment support. Next slide, please, Kathy. Great. So community integration and social supports. So this is also a funded service for folks that might need additional support around social activities, maybe companionship type services, riding public transportation, that sort of thing for folks with certain disabilities and needs. And then finally, case management support. Case management assists eligible individuals to gain access to certain medical, social, educational, other services, and can really be used to address a broader range of needs and to assist Medicaid and CHIP, which is the Children's Health Insurance Program, beneficiaries with accessing Medicaid or other non-Medicaid services. And also, it's important to note that states can target this benefit to specific populations, certain Medicaid eligible populations, I should say, including folks with substance use disorder that are experiencing or at risk for homelessness, transition age youth coming out of foster care, individuals transitioning from medical institutions, or older adults with chronic medical conditions. They're also not required to make these services statewide, and they can really be targeted for particular populations. So great. Next slide, please, Kathy. So now that we have a stronger understanding of what are some of the broader buckets of these services and supports that are covered in this particular guidance letter, I'm going to let Marcella walk us through some of these state examples.
All right, thanks. And next slide, please. All right. Many states are beginning to build what is called commonly a closed loop referral network. A closed loop referral network is really a technology solution. It's an information age perspective on the resources are out there. We just don't know where they are. They're increasingly large companies, Unitas, Ampertha, NowPow, though I think Unitas just bought NowPow, et cetera. And it says, okay, where are all the resources? Where are all the, where are all the food pantries? Where are all the shelters? Where are all the housing related resources? Any one person can understand all of those different resources that are the people that we're working with in health centers need to be able to access. So this really brings all of that information together in a variety of different ways to really facilitate the referral system. I do want to highlight it's really important to folks with a lot of challenges in their lives. They need more than just information. They need actual access, and that warm handoff theme you're going to hear me making again and again. Some communities are building up their 211 system because that's really what that 211 system was designed to do. San Diego has really one of the best in the country. North Carolina has put enormous resources into what's called NC Cares 360. So there's a couple of things to know about these different systems. One, like any other information system, they're as good as the information that goes into them. So states are putting different levels of effort and increasing amounts of engagement to get community-based organizations in order to bring their information in. as I said, this is a technology solution. It makes a simple referral system, but sort of what are the barriers and what are the gaps, and whether there really is capacity. I like to say this is that these systems are going to tell you where all the food pantries are. They're not going to fix the problem that sometimes in a food pantry the cupboard is bare. But what it can do is it can help you determine how many times does the cupboard bare? Who is it? Is it, what times of the month is it bare? What times of the week? It gives you new information so you can begin to address those gaps. So these systems give you better information, and we're working with many of these entities at CSH in order to say, let's make sure that we build out that understanding that gap so that we can build out those gaps. And the slides, okay, thank you. So let's talk about North Carolina. They're doing some of the earliest and most and the largest efforts here around the NC Cares 360. It's a new tool for healthier North Carolina. It's a partnership between the state and philanthropy, and it's basically building out a North Carolina resource referral platform. North Carolina is determined they're focused on 4 social drivers of health. They're focused on housing, they're focused on food and nutrition, they're focused on transportation, and they're focused on what they call interpersonal violence. That can be domestic violence, that can be gun violence, that can be any interpersonal violence. And when you need to be referring from a healthcare perspective, you see that the person you're serving can't can't engage with the health system, can't work to keep themselves healthy if they can't access these things, housing, food. These are the basics here. Then you can go into this NC Cares 360 and build out the platform. It's exciting. It's going to take a lot of work, and it's only as good as all of the information that goes into it. So the state's really making an enormous effort to try to engage those community-based organizations and then build the capacity of those community-based organizations. We see this as really a pathway for Medicaid billing for many of these community-based organizations. So they put their, what they do, they put their community perspective on the state's radar screen in new and unique ways, and then that begins a dialogue with the health plans, begins a dialogue with the state, et cetera. So lots of states are beginning to build these out. I believe Arizona is doing one as well with NowPow, and trying to address the information gaps in the community-based resources that you'd like as a health center to be referring your folks to. My guess is that you're also doing a fair amount of social determinants of health screening, but now that you've got the data, the question becomes, okay, 10% of our folks we're serving are housing unstable, where do we send them to get that kind of assistance if we don't know? These systems are the systems that are being put in place to try to help you answer those questions and figure out these partnerships. And yes, if there are other platforms, please let us know. We're trying to get a comprehensive list of those so that we can share it with all. So yes, some of these are being done statewide. Some of these, so the platforms are also being done statewide, and then some are being done community by community. California for the past 6 years has been operating under an 1115 waiver, what they call the whole person care pilot. So they'll have 6 years that they've done in 25 counties. The counties could decide whether they wanted to address this or not. They were looking at coordination, using the resources in whole person care to coordinate both physical health, primary care, behavioral health care, and the variety of social services and community-based needs that people present with as well. There were startup investments of $100 million in housing support services in the FY19 and 20. That's been really helpful to support housing providers in particular, because they're not used to billing Medicaid. And they've done investments in outreach and engagement to an unsheltered population, to a incarcerated population. They're building universal social needs screening in Costa County. They're doing specialized transfer of care teams. So I'm in a nursing home, moving to the community. I'm incarcerated with multiple disabilities and moving to the community. I need a transfer care team to make that support. They're doing cross-sector case conferencing, community health worker training and support. Community health workers is really just going to explode with the funding it's had over the next couple of years, and making sure that those folks are trained and supported in this, have access to the information they need to do their role and be effective. And then again, near and dear to our hearts at CSH, the housing transition and navigation services, helping people leave institutions, helping people leave homelessness with these housing and housing related supports. That 6 years is up at the end of this year, and California is working hard to move to, next slide, please, what is being called CalAIM. CalAIM is looking at services that are called enhanced care management services. They are doing what they call community supports, or what's now in lieu of services, and other services as well. All of this is going through the health plans. CalAIM really focuses the center of attention in healthcare delivery and healthcare access to the health plans across the state. The state's looking to make more uniformity and more, so there's less differences county to county. The state has also, as I think I mentioned this before, put in to their home and community-based services, American Rescue Plan Act funding, over $1 billion for incentives for MCOs to begin to address housing and homelessness across the state. Homelessness it's a crisis everywhere. It's a tragedy everywhere. It is a special level of tragedy in California and crisis, et cetera. And the level of attention that Governor Newsom's office is paying attention to it is really important. So these are some partners. You want to know who's getting this funding in your community. If you're serving people experiencing homelessness, if you're serving people experiencing housing instability, then you want to know who's getting these resources. What's the plan? You want to get to these tables and say, we offer primary care, we offer behavioral health care, we know how to bill Medicaid, we have contracts with MCOs. You want to say, these are the things you know, these are your strengths. And then you also want to say, but these are the things we don't know, and we need partners who know how to do that. We need partners who know how to do homeless work. We need partners, if you don't know, maybe you do, if we need partners who know how to do housing development and financing. We need partners who understand our coordinated entry system, which is how people in the homeless system access housing and other resources. We need to understand these systems well enough in order to make the referrals and make the partnerships that we know those we serve in the health center need. There's also 100 million in capacity building grants for community-based organizations, particularly homeless shelters, housing developers. They don't know how to build Medicaid and develop their internal capacity. Always thought that that's a great opportunity for partnerships to begin to be put together. You as health centers come with the expertise in Medicaid and Medicaid billing and the administrative pieces. You know how to do that well. Find a new partner who knows how to do something you don't know how to do, like maybe develop housing, like maybe navigate the coordinated entry system. So that's the future, is CalAIM. We believe California, we're hopeful that California will move towards a tenancy support services benefit across the state. Next slide, please. And now we want to think about the role of health plans. I know health plans might not be sort of front and center from a health center financing perspective, but in a lot of places, California was just an example. Health plans are becoming, or managed care entities, managed care plans, managed care organizations, managed care entities, MCEs. You may call them something different in each of your state. They really all mean the insurance company that's covering people on Medicaid. Maybe you work closely with them in your community, maybe you don't, but they're going to be a really central driving role in many, many states around the social drivers of health work. And if you want to stay connected to that, you want to get connected to your health plans in new and exciting ways. So next slide, please. So health plans are being held accountable for outcomes at the state level, and health plans are smart enough people to know that this leads to a new emphasis and a new level investment needed in SDOH. States are targeting particular populations, complex care populations, behavioral health populations, and learn where that is and where those priorities are in your state. If those are the people you're serving, figure out what tables you need to be at in order to be part of that conversation. So it's sharing the voice, or bringing the people with lived expertise who receive services from your health center, and really pushing forward on where health plans are making those investments. They're targeting outcomes. States are also beginning to target outcomes, not just for the whole community, not solely for individual health plan members. So I learned a year or so ago about a really exciting program in Michigan, where instead of, historically, health plans have said, okay, this group of people, these are my members, I'm going to do everything I can for them, et cetera, to improve their health, to reduce their costs. But all those people over there, they're not really my concern. They're not my members. States are really pushing the health plans to take a broader, more community health related outcome. And that's a really exciting possibility as well, particularly as you look at the investment that health plans are being asked to make in communities. And that's really been kind of a rub for the housing sector in particular. We can't build a building and say, okay, we're only going to take in health plan A members, but not health plan B members. So we're excited for this broader focus on community. We also think that this is going to have a lot of impact on equity. We know how much communities of color have struggled in order to access and access Medicaid, access services, be health plan members. And so we think that's going to be some more broader community-wide focus we think is going to be really important to address health equity and improve health equity in our communities. So increasingly, they're taking a community-wide role. Next slide, please. So health plans can do a number of different things to begin to address some of those social drivers of health. A lot of the for-profit plans are investing in what's called low-income housing tax credits. This is the primary driver of development of affordable housing in your community, et cetera. And so they're making that investment. They generally speaking have to develop social determinants of health plans based upon different state directives. This may be community-based care management. Back in the day when I used to work in care management, I was in a downtown office, I was in a cube. We never left that cube. That's changing. People are being moved into the community, and that care management role, that really looking holistically at what a person needs to be healthier and succeed, not just from a health perspective, but from a whole person care perspective. We don't say, oh, housing's not our problem, food's not our problem, we're looking at medications and doctor's appointments. Now we're going much broader than that with a community-based care management role, and many health centers, particularly in California, are getting into that community-based care management role and getting closer to the ground and seeing really what's going on for people. Health centers are increasingly doing screening. Their health plans are doing screenings. They're looking at their data and they're making their investments based upon their data. And they're collaborating with community-based organizations who address social determinants of health needs. So that could be your local food pantry. That could be your homeless shelter. That could be your housing authority or housing developer. That could be different community-based organizations that try to prevent domestic violence, working with the perpetrators, working with the victims. That could be working with victims of gun violence and working with perpetrators of gun violence to try to stop that tragedy as well. And then health plans are also looking at all of their data, looking at what's coming up from screening and beginning to make some investment, saying that we're going to invest in this food pantry in the neighborhood that we've targeted where food is really, lack of food access is really an issue. So it's very, very data driven. It's very targeted and prioritized, et cetera. And it's an important conversation for health centers to be a part of because they are very close to the ground. They are the ground in many places, and working with your patients and the people you serve. Health plans will begin to get involved in policy and advocacy efforts for affordable housing. Always have to mention that 1 in 4 Americans who qualify for housing assistance can access it. That means 3 out of 4 can't. So getting involved in those policy and advocacy efforts to try to change some of those numbers so that housing is not the scarce resource it is. Advocating also for benefits access, for home delivered meals, and for many of the similar goals and objectives that your health center may want to do as well. They're doing pilot programs to address health plans for targeted populations. They're looking at maternal health. They're looking at what are the deepest inequities in our communities around health and how do we make changes there, and investing in those pilot programs to make changes. I think states are moving or will be soon coming to the day where health plans are also, shall we say, held accountable for health inequities in our community and what are they doing in order to address those health inequities. And as I said, they're implementing screening for their members and then investing where the screens and the data show the greatest potential for impact. So health plans are really getting involved in an SDOH plan. And I think it's really, really helpful to health centers to be part of that conversation, to help drive that conversation, to share your data, to share the voice of the people that you serve, and make sure those investments are happening in the places where they will have the most impact and build equity in our communities. Next slide, please. Jamie, do I turn it to you now?
Yes, we are going to be pivoting our conversation to talk about, what does this all mean and the impact ultimately on health centers in this broader discussion about social determinants of health. And I just also wanted to take a pause and for anyone who might have some questions that you might want to drop in the chat. There's a lot of information that we're sort of bringing to you all at once. And so please don't hesitate if you have questions. We're very happy to pause and sort of walk back through any of the points that we've just covered.
What you're seeing in your you're seeing in your communities and how that lines up or does not line up.
Exactly. I think it struck me something, Marcella, a bit when we were talking about the platforms like Unite Us and NC360. And, not every state is building out these types of platforms, but it got me thinking, it's not necessarily not having access to that particular platform does not preclude you from being able to continue to address social determinants of health through new partnerships. You don't necessarily need a closed loop referral network in order to go out and form new partnerships. And so if anyone has thoughts on that or on the work that you're doing presently in your state that maybe doesn't have one of these types of networks that's being built out in California or North Carolina or others, we'd love to hear a little bit about that as well. Because I know some of the biggest lesson learned around a lot of this is that it's not just enough to screen for it, but that what are the next steps beyond screening and capturing the social determinant of health data at the health center and patient level, but that what are the extra steps done to make sure that should the patient wish it, that referral, as Marcella kept mentioning, warm handoffs is actually followed through and the person is actually connected to the resource beyond here is a phone number for your local community action agency, good luck. But how are we really assisting folks in actually obtaining access to the resources that they need to have the impact that we're looking for? Great. So next slide, please, Kathy. Great. Next. Excellent. So really the biggest impact that this increased focus on social determinants of health and Medicaid stepping up to provide some of these tenancy support services. And so what is the broader impact on health centers, but more importantly, the patients that you serve is furthering of efforts to improve equity and then ultimately reduce health disparities and improve some of these outcomes. And this is ultimately going to be achieved by engaging with your local communities, understanding the needs. A lot of folks are already doing that through various mechanisms to understand what the needs are in their communities, but then ultimately taking it further and using and sharing data, so harnessing that data, and then addressing other larger structural factors that are going to have an impact more upstream. And that's when we bring it back to the discussion around housing, again, is a big, big one. So next slide, please, Kathy. Great. And so to further this conversation around equity and disparities, particularly racial disparities, we just want to take a moment to highlight one of the tools that CSH has. You can access it at csh.org/data, is our racial disparities and disproportionality index. So it allows you to see across different systems in your state where certain disparities are. Racial disparities are. It's a very useful tool. So if you're interested in diving in a bit on the data in your state, I really, really encourage you to go. So csh.org/data if you'd like to take a little bit of a deeper look at this tool. And again, if folks have questions, happy to pause to dive in a little bit more on that. So again, taking this further, what are some of the best practices in furthering work around social determinants of health? You know, in our experience at CSH, working with communities and states across the country, you know, we are found that these are some of the sort of top level factors that contribute to some of the more successful efforts and greatest impact. So data sharing. So this can look like a FUSE initiative, which is frequent user system engagement, whereby you do a data match across multiple systems, health systems to maybe the homeless management information system, HMIS, or perhaps justice data to identify where some of those frequent users are. So it can look like data sharing. It can look like coordinated data. It doesn't necessarily have to be across all systems. It could be memorandums of understanding with other organizations or data sharing with just the homelessness system to become, or integration within the homelessness system so that you can become, get access to the coordinated entry system in your state, or even better, to become official access point for coordinated entry, so it eliminates the need for an additional referral. There are health centers across the country that are what we call that access point for coordinated entry. So when someone is screened and is identified as either homeless or housing unstable, you can make that referral direct into the HMIS system without the need for an additional step on behalf of the patient. Great. New partnerships, so connecting with other service providers to meet identified needs. So this might be outside of your normal sphere, it may require reevaluating existing relationships or broadening existing relationships to think about meeting some of those needs that perhaps you have not done before. Braiding funds. So with new partnerships, there might come different funding streams that, when properly braided together, can open up new opportunities, particularly around housing development. So a good example on that of braiding funds can be the new American Rescue Plan funds with low-income housing tax credits, for instance. These are examples of braiding funding streams together that provide you the capital, operating, and services dollars necessary to provide housing. And then finally, and Marcella talked a little bit about this, but joint policy advocacy. So alongside these partners to collectively advocate for upstream interventions that will ultimately have a broader impact when everyone is advocating together to address these systemic and structural factors that impact social determinants of health and patients on a broader scale.
And Jamie, we can send people slides, correct?
I believe so. Yes, we will send out a link to the recording, and you'll be able to view these slides as needed if you joined us late, or if you need to share them. No problem. No problem at all. Great. So, how are states? What are the uses for the new funds that are coming down? Particularly around American Rescue Plan funds, as well as Medicaid home and community-based services. And so you can see a number of states are using provider supports and workforce supports for those funds. But when you go down, you see cross-sector partnerships, SDOH, transitions to the community, caregiver support. So there's a number of ways that these funds are being applied across the country. So I really encourage you to dig in and see how your state has plans for these funds and how they might be leveraged. Great, and I want to just pause here. Marcella is dropping some resources in the chat for you all, especially if you are less familiar with what we talked about regarding the homeless management information system and other things relating to housing instability and homelessness. So if you have questions about any of the things that we've mentioned or want to dive a little bit deeper, thank you for sharing those, Marcella. So other questions. This would be our opportunity. We have we had planned for about an hour and a half, but I think we might end up using just about an hour of your time today. But if there are, before we sort of proceed with the last section of our presentation today, we really wanted to take a moment to see if folks have more specific questions, you want to dive into an aspect of what we've talked about. We're really providing this higher level overview, but happy to jump in the next 10 minutes to dive in a little bit deeper if folks have more specific questions. I'll just give it a pause here. I think really the ultimate takeaway from this is that this is moving into a new era where there's a new historic opportunity to broaden partnerships and opportunities to improve have an impact further upstream than ever before when we look into some of the opportunities and different funding that's availability and health centers and how they can get involved in addressing social determinants, which will ultimately have the bigger impact on improving health outcomes long term. We did have a question in the chat. I'm new to housing. Where in California can I get more information about housing and how to assist patients? So
Marisol, it would help us to know what county you're coming from, because that answer is very different county to county in California. So maybe we'll go to the next question until we find out where she's from.
Sure. And Dory says, is there more of a collaborative between HRSA and CMS funding?
All right.
And then read this.
So the answer is yes. there is meaning, hold on for a second. So Marisol, okay, I'm sorry, I'm bouncing between things. Okay, so Marisol is in Los Angeles. So Marisol, you want to be connected to the Los Angeles Homeless Services Organization, or what's commonly called LAHSA, for your health center. And how can your health center get involved in that work? How can you make referrals to coordinated entry? LAHSA, I believe, is one homeless system and coordinated entry system that allows outside entities to make direct referrals, like Jamie talked about, into the homeless system. So that's really helpful there. Jamie, you were jumping into the, let's see.
We had one more, we had just one or two more questions. So we wanted to address Dory's question, which is there more of a collaborative between HRSA and CMS funding? So if you wanted to address that one, Marcella.
So I would say, yes, it's building. I would say one thing that is going to hold that together is health equity. I mean, from the President's Day One order around equity, all of them have to come up with strategies. I was actually just on earlier this morning on the National Medicaid Directors Conference, and Secretary Becerra talked about that level of collaboration that's new between departments and within departments within HHS. I can't point to anything specific, but they're all focused on equity. And health centers are just such a profound partner in the work to improve health equity in our communities. So it's probably coming, but I can't give you anything specific yet. But certainly partnerships was something the Secretary spoke about as well this morning. So that means both partnerships within, CMS and within HRSA, and that means partnerships with your community-based organizations as well.
And then I wanted to highlight Rita's question as well. How easy or hard is it to get health plans on the same page about how they address SDOH?
So what I would say is that the recommendation that I would give to people is that you really want to push at your state Medicaid office level in order to do that. I think health plans are always more focused on what the state's asking them to do in their contract than they in anything else. So the places where we're seeing those most strongest investments are the places where the state required those investments. So I think you start your advocacy efforts with the state Medicaid office and you say, we want to make sure that screenings required from the health plans. We want to see this data on a regular basis. We want access to this data. We want to be able to contribute to this data on a regular basis. We want to see investments in social determinants of health in our communities. Can you add that into what's being required and requested of health plans, and get to those tables particularly where Medicaid takes feedback from people with lived expertise, from health centers and other entities, and say, these are the barriers we're seeing to good health in our community. Some of them may be care-related barriers, but my guess is many, many more of them are social drivers of health barriers. And how can you target that? How can you get that theme at the state level so that the state's really pushing on the plans?
Great, and there's actually a few more questions in the chat, if I may. Would you say, Sharon asks, would you say SDOH are underestimated? Many health centers in Maine are not capturing this information on claims. A federal push to include this info on claims, possibly by paying for an SDOH screening, would improve capturing of data. You want to take that one?
Sure. So I think what's important to know is that it's required in some places, it's not required in others. Where chat is going on, I don't know whose screen. Yeah, we need to get back to the slides and away from the chat, everybody. Sorry. I don't know whether that's Kathy.
That was Kathy.
So yeah, okay. So let me say a couple of things. One, we are utterly sure that SDOH is underestimated in the data that the health plans are capturing. We're looking to improve that. So for example, there are 2 Z codes in the ICD-10 that looks at homelessness and housing instability. We know that they are underrepresented, underreported, and we know that what was I going to say? And we know that states are looking to get better data. Part of what Jamie talked about was that data sharing is one of the best practices, is because far too often health centers or health plans may screen for who's experiencing homelessness, but then when they match the data with the actual homeless data in their community, they find a huge numbers of people that were that were underrepresented. So I think I think back to my own early, I started as a clinician. I'm like, data, why do I have to worry about data? I'm treating people here. But making sure that that data is accurate, making sure that that data is quality, and making sure that that data begins to reflect, not even accurately reflects, but let's get closer. Let's set a goal of getting closer and having higher quality data about how much social determinants of health needs are in place. And that's also the potential that we really see in these social referral, the closed loop referral network platforms, is to really try to address those gaps. When I used to manage a system of homeless and housing, people would ask me, what do I need? How much more do I need? And the answer is, I need more. And we're getting to the point where we're getting the tools to be able to not just say, I need more, but at CSH, we've estimated a 1.2 million additional supportive housing needs units nationwide. You get further in your conversations when instead of more, which is right, you can say 1.2 million, and that we've determined within these systems and within these methodologies. So I think we've all got to take data really, really deeply importantly. And if we feel that underestimates are in place, we need to call those out. We need to use the best data we have, and then we need to get better data.
Thank you. And we have one more question, and I want to thank everyone for sticking with us as we go through these questions. We have one more. I want to make sure that we get to before we wrap it up. Are there any specific advocacy initiatives around this topic, around SDOH, being supported by USICH, which is the United States States on Homelessness? Yeah.
Yeah. So the answer is that Interagency Council is focused right now on redoing their strategic plan. This is something that is common in the first year of a new administration. They have a plan that was under the former administration. They're making a switch. They're shifting it to an emphasis on equity. They're shifting it to an emphasis on values. So the answer to your question today is no. And quite honestly, I'd be shocked if in 6 months the answer hadn't switched to yes. We haven't seen it yet, but I expect it to be coming soon. And I think there's a level of collaboration that across social determinants of health, that people are actually looking at the U.S. Interagency Council model and saying, hey, getting all of these federal departments together to address a really complex issue like homelessness in our community makes a real difference. Can we do this around social determinants of health? Can we do this around aging? Can we do this around other really complex issues that our communities are faced with? So today, no, stay tuned.
Okay, great. And so we're going to be putting up, I want to thank everyone so much for the wonderful questions and this great discussion. We just have a couple things that I want to remind folks of. And then if you could please do our evaluation poll that will be popping up shortly. Kathy, if you could go to the next slide, please. There's just a few events we would like to highlight for you all to further this topic around social determinants of health and partnerships. There's a few upcoming events that you might be interested in, and if you have not already registered, please do so. On December 9th at 1 p.m. we'll have a health and housing partnerships webinar on online tools and resources to further those partnerships. I will drop the registration link in the chat for everyone. Next slide also, please, Kathy. Also, please save the date. Application period will be opening on Monday, December 13th for our Capital Expansion for Health Centers Learning Collaborative. This is a 4-session learning collaborative all about understanding development and how to form those partnerships necessary to get in that housing game, if you will. This is a very interesting series, so I encourage you all to take a look and check it out, please. And our applications will open for that collaborative on the 13th. We'll be sending out more info for that as well. Great. So if folks could please just take a second to fill out our evaluation poll for today's webinar, and thank you all so much.